Ms. Callisto, Professor von Seegesser, thank you for the privilege and the invitation to share with you a critical review of a manuscript. I have a dog, and the dog is a Lagotto type dog. And when he hears a strange noise, he comes closer to me and looks at me and asks what it is. And of course, that's a possibility for a dog. And there are dogs, certain pit bulls, who really fight into the incoming enemy. So what is a critical review? Is it an art? Is it a science? Or is it a game? Well, it is really intended to be very serious, because there have been manuscripts, and I'm thinking immediately on one even coming from our own institute, not from our own department, but from our own institute, who was immediately picked up by guidelines and has cost thousands of patients' lives. So a publication of a manuscript can have dramatic consequences. And if the people had done the critical review a little bit pit bull type, they would have discovered that there were major mistakes. So of course it starts with the title. Is the title appropriate? And I give you some suggestions here for titles, and then you have to worry what is really the intention of the authors, and does the title correspond? So the critical review starts already with the title. The authors for me are totally unimportant, because as soon as you start paying attention to the authors, you get biased. So don't pay any attention to the authors, because if that's the way to do, you're immediately biased. So, and then in that title you see certain definitions. So what is severe COPD? What is severe coronary artery disease? What is CABG? We saw 2 days ago in one of the breakout sessions that somebody used the word OPCAP. And I challenged him. I said, how is your primary variable defined? And he could not answer it. So for me, immediately it destroys whatever consequence is made if you don't define it. And so when I've read that title, I then say, what are my expectations of the content, and what are my expectations of the inference building that can be made? And I give you an example here on a study, and the study had as title, and I have copied it, Critically Ill Patients. And I have some impression about what a critically ill patient in shock, a patient with massive endocarditis and sepsis, a patient who comes after a major trauma. That's for me a critically ill patient. But in reality, what you see is that the title does not correspond at all with the methods. This was published in the New England, and it says, adult patients admitted who were receiving mechanical ventilation. Are these critically ill patients? It turned out that 85% of these patients were after normal cardiac surgery. These are not critically ill patients. They need to be monitored. Do they need to even go in intensive care? I'm not personally convinced that every patient should go in intensive care, and there are units who in the same bed, after 6 hours, liberate the bed and go for the next patients. So for me, absolutely incorrect title. And then there's titles like left main in PCI versus CABG. Well, then immediately, for the critical review, you need to know a few things. Is left main an issue in coronary surgery? Well, there is science about that, and we know that the impact of left main has totally disappeared in coronary surgery on the risk. So there's no more risk. So we're talking here about risk in a certain subset of the data set and no risk in the other data set. And that needs to be in the critical mind of the reviewer. And then we go down to material and methods. And we're looking for, because we're not reading the introduction. Really, in reality, I'm very honest about that. I never read the introduction. I'll only read the introduction once I'm happy with all the rest of the manuscript, because then I will start reading again. And in the material and methods, there are some statements like randomized control trials. If you have been at every annual meeting of the EACTS, I remember very well an abstract that was selected in the Glasgow meeting, and it was selected with the top 5. And it was about randomized, it stated in the abstract, randomized control trial, RCT. It was picked up by the reviewers just because they saw that word randomized control trial. It was an absolute ridiculous manuscript, totally underpowered, nearly every mistake having. But it was selected as one of the top 2 or 3, but that's the abstract review process. So don't be bothered by the fact that it states somewhere randomized control trial. No, now go for the next steps. Because for each type of study, there are rules. We've not made these rules. Professor von Segesser has not made these rules, but other people have made these rules. You have to follow these rules. In this presentation, as an author, in this presentation, I will not go over the details of these rules, but you can look them up, whether they're called Consort, Strobe, Moose rules. They're all well defined. And if you want to do a really critical review, you should have them next to you when you do that review, and this will help you. In fact, if you don't know where to find them, just type in Google Scholar and you write randomized controlled trial rules, and immediately they will come up. So it's not very difficult to find them. The next thing is, do we have the correct sampling? Mrs. Callisto just talked about another group. Well, for example, they're comparing PCI versus coronary surgery. And then my immediate question is, so what about natural history? Are we so certain that there's no place for natural history? And is there not a major deficiency in the design of the study? The cardiologists have not been unhappy with the Courage and the AOT trial, and they've discovered that, in fact, natural therapy can have and outperform interventional therapies. The next thing I look at is the descriptive variables. And what I want to see is how rich is their data set. If they classify things like COPD, yes or no, for me that immediately is so poor as a data set. No, what I want to see is, do they have a vital capacity in actual numbers? Is this a continuous variable? How rich is their data set? And for the same variability, we want several variables in the original data set. That will enrich the data set. The next thing, definitions. Some definitions are totally arbitrarily, and I show you here a couple thousand troponin I values. I don't know where the cutoff is of infarct or not. Of course, on the right side, it is clearly an infarct, and on the left side, it's clearly none. Where is that? Well, some rules were decided, and I must say very often, I don't know if that on itself can make a definition, so make sure that the definition is used. Baseline comparisons, yes, it helps in a study to have some visibility, but of course we should know that a p-value is a totally arbitrary definition of 0.05. I'll give you an example of an article published, don't go into the details, it's just for the story, an article published in the New England. As you can see there, she has the baseline comparisons on the left side, and there's no p-values, but they give the impression as if the patients were equal based on the Apache score. And for me, as the Pitbull critical reader, I go to the area under the curve of the Apache score. I want to see what is the validity of the model, of the Apache model in comparing data. And what do I find in the literature? So I type in Google Scholar Apache score, and I find it's only an area under the curve of 0.75 in its most recent publications. So for me, this is an invalid comparison of two data sets. So there's no proof for me that the data sets are the same. We should also know that risk is not in the average values. You have a data set and the average value is 56.7 years, and the other one is 56.8 years. Is this an equal data set? Well, if the risk is around 50%, then 80% may be, but the risk is usually very low. And where is the risk situated? The risk is never in the median or in the mean. The risk is in the outliers. So what I want to know is how many patients are 90 years old? How many patients are 80? This is where the risk is. This is what I want to know. I don't care about an average value. Randomized controlled trials take their roots in the basic science experiments, and you have beagles with the same weight and the same genetic component, and that's easy to randomize this. But if we bring this into the clinical world with this huge variability of patients, we must make sure that we have done this correctly. Outcome events. Major mistakes in the outcome events. Every discrete event can be an outcome event, but it must not be biased. Look at the syntax trial. The syntax trial is 4 events: death, stroke, and infarct. Whether infarct was defined correctly, I cannot answer that. I really cannot answer that. After 30 years of coronary surgery, I cannot answer if that was a correct definition. But the fourth event is re-intervention. Re-intervention is a medical decision. It's not an event. It's a medical decision. Cardiologists can decide to re-intervene or can decide not to re-intervene. So therefore, and it turns out that this is a huge event in numbers and in percent of the total MACE. So in this total MACE, they bring in a massive fourth event. If I look at the literature, I see no evidence that it makes sense when there are 3 arterial grafts open, that it makes sense to re-intervene in the patient and open up a fourth vessel because a venous graft to a bad vessel has occluded. So in fact, they're bringing a massive bias into this study. And I've said that to Patrick Serres when he started. He didn't listen. Now he understands that that is what made him on the bad side of the results. And in the Parexel trial, they've gotten rid of that re-intervention episode. The power calculations, you can redo, or you must have some idea about the power calculation. And of course, we all know why we have combined events. It's because of this power issue. Correct observation interval. Why do we continue to talk about hospital mortality? The hospital interval is a biased event. You can send, in some countries in the United States, they send the patients home day 5. No, they're sending them to the hotel on the opposite side of the street, and they publish the hospital mortality. It's totally advanced. In Germany, you can send the patient to a rehab center maybe for the next 6 months. The patient is not home. But that's also a form of hospitalization. So hospital events is no representation of the risk of the care, and certainly no representation of the quality of care. 30-day events. Why 30 days? As if 31 days is not related maybe to the surgery. So we have to stop using these 30 days. I mean, no manuscript impresses me when I look at hospital mortality or when 30 days. And we should please stop calling 2 or 3 years late events. The correct method has been shown to us by Blackstone and Kirkland. What he does is hazard functions, and based on that hazard function, then define the correct interval. On the top left, you see for stroke that the correct observation interval maybe needs to extend up to 15 days. For infarct after coronary surgery, with the first 5 days, you probably include the largest interval. For return of angina after coronary surgery, well, you can see very clearly on these hazard functions that the early risk extends up to 15 months. So every event for every therapy will have a different observation interval. That is what the science of outcome analysis has learned us. Follow-up methodologies. In the method section, I want to see how the follow-up has been done. There are rules about that. Typical 2 classical rules is common closing date method or anniversary method. I want to see that, which method they have used. If they don't cite it, they have not used any method. I want to see that. It has to be stated. In addition, I want to see how much information is missing in percent of days or in percent of patients. I want to have that information and find it. The next step, we go further in the critical review, and the pit bull is fighting and biting more and more. We then look into statistical analysis, and in statistical analysis, I find something like the 4th interim analysis indicated that conventional treatment was inferior and the study was stopped. Not by a Data and Safety Committee, published in the New England, not by the Data and Safety Committee. No, there was no Data and Safety Committee, and I know because I know the backside of this study. So the authors had been looking all the time at their results, and in fact totally arbitrarily decided to stop the trial because all of a sudden the p-value was reached. A nice little problem is in the Ruby trial, where there is a nice plot in the New England table 3 about graft patency. But nobody reads, of course, the manuscript, because in graft patency you can see that 75% of the patients declined the angiography. So we're only having data on 25% of the patients, and now my next question is, why did the others accept angiography? Because they had symptoms, or what was the reason? Totally invalid table for me, table 3, published in the New England. And then, of course, when you really want to bite hard, you recalculate the p-values a little bit. Now, I do that on my mobile phone, and what I do is I recalculate the p-values, but what I do is I start playing with it. Now I'm adding 5 patients on, so moving 5 patients from one category to the other and seeing how stable this result is. And what you see is all of a sudden p-values appear or disappear, and could very well be that 1 or 2 patients the p-value is less than 0.05. And of course this 0.05 is an arbitrarily value. It is arbitrarily 0.05. I agree with that. But the authors are so happy with that number. And then strange things appear. I'm sorry for my slide. The sponsors biostatisticians performed the analysis. That makes me very nervous. And then they say something like the data were verified. What does that mean? The data were verified. So somewhere in the process, the lessons we have learned, there's maybe a failure of the authors, there's maybe a failure of the peer pressure on the in-house statistician, and I know that has happened in several major institutions. There's a company-based statistician, there's a company-based writing. Many of the manuscripts are written by the companies today. And how do you discover that? Well, what you have to do is ask the slides that they present. And then when you ask the slides, try to deconstruct some of these slides. Take the original slides. You find strange things when you deconstruct the slides. You see the nice slide presented in the presentation, you take away some of the elements of the slides, and all of a sudden you find strange stories sitting behind it. And of course, too bad it works. I'll give you an example of a manuscript, and this is my last slide, Mrs. Callisto, Professor von Seegesser. The consort rules in this manuscript were violated. Rule number 4 was violated, rule number 6 was violated, rule number 7, rule number 8, rule number 10, 13, 17, 18, 20, 21, and 22 was violated. But brilliant, the manuscript was cited in the first 36 months 80 times by the Annals, by the Journal of Thoracic, and in fact it was even cited in meta-analysis. So the manuscript is going, but it failed on nearly every single aspect, and I thank you.